Good evening. I welcome today's speaker, Dr. Ameet Singh from Ontario, and all the participants to this webinar of Indian Society for Veterinary Surgery. So, briefly, I would like to introduce today's speaker. Dr. Ameet Singh is an associate professor of small animal surgery at Ontario Veterinary College, University of Guelph. His clinical and research interests include minimally invasive surgery and surgical sites infections. Dr. Singh is currently working as president of Veterinary Endoscopic Society and is an ACVS founding fellow of minimally invasive surgery. He has published over 100 journal articles and textbook chapters and taught numerous workshops and surgical courses all around the world. Dr. Singh received his DVM from Atlantic Veterinary College and completed his surgical residency training at the Ontario Veterinary College, University of Guelph. His clinical and research interest includes advancing the evidence based on the use of minimally invasive surgery in small animal soft tissue surgery. Looking to his significant contribution and knowledge in the field of laparoscopic surgery, I request Dr. Ameet Singh to deliver today's webinar on laparoscopic treatment of adrenal gland tumors. Dr. Ameet Singh.
Great. Thank you very much for that kind introduction, and thank you very much for having me for this webinar. It's a phenomenal society that you have, and really appreciate the invitation once again. I hope that everyone is staying well in these kind of crazy times. So I wanted to, do the webinar today on laparoscopic treatment of adrenal gland tumors. I'm not sure how many of you have been approaching these tumors. They're not the most common diagnosis, but certainly they're one of mine to treat, whether it's open surgery or laparoscopic. Certainly depends on the the tumor, the invasiveness, things like that, which we'll talk about. So just before we get into the webinar, if any of you want to learn more about minimally invasive surgery, certainly please feel free to visit this website. It's called veterinaryenendoscopysociety.org. This is the website to this amazing society. We've been holding many educational events, similar to ISVS, and would love to have more members. And so if you're interested, please visit the website. Other resources that are out there. This is a special issue on minimally invasive surgery. This is in the journal Veterinary Surgery. And, if you have access, there's certainly a lot of minimally invasive literature in this journal. Another great resource is this textbook called Small Animal Laparoscopy and Thoracoscopy, which is edited by Paul Franson and Tim Macy. Certainly lots of great info in both of these resources. Okay, so let's talk about adrenalectomy, specifically laparoscopic adrenalectomy. The first procedure of laparoscopic adrenalectomy was performed in the early 90s. So, not that long ago, if you think about it. It was first described in the New England Journal of Medicine, and it was then continued for other types of adrenal gland tumors, so commonly pheochromocytoma, which are originating from the adrenal medulla, and then adrenal cortical tumors that result in overproduction of cortisol, which leads to hyperadrenocorticism. So what's interesting, though, is that, in this schematic diagram on the left, the adrenal glands in people, they're more associated with the kidney than they are with any major vascular structure like they are in dogs. In dogs, we see a lot of cases that are invading the caudal vena cava. And so it's a big anatomical difference in people versus dogs. So no surprise, over the years, laparoscopy has become the standard of care procedure for the majority of adrenal tumors. And you get the class in laparoscopy compared to open surgery, so reduced blood loss, morbidity, shorter hospitalization time, which makes the procedure, when it's done laparoscopic, more cost effective. The one very interesting point, though, is that now over the years, this is a paper from 2012, but adrenal cortical carcinoma in people seems to be a highly aggressive, both locally and metastatic risk disease compared to dogs. Most tumors of the adrenal gland that are resulting in hyperadrenocorticism are carcinoma, and we don't really see a high recurrence rate, versus in people, this is completely different. It seems to be much more locally aggressive and higher metastatic risk. And so some groups have stated that laparoscopic adrenalectomy for these tumors is not enough. And so there are some groups that say these tumors, again, adrenal cortical carcinoma, should be performed by open adrenalectomy. But there is much debate about this particular type of adrenal gland tumor. Okay, so what about dogs? What are the most common indications for adrenalectomy? We mentioned it. So adrenal cortical adenoma or carcinoma, these can be functional or not functional. Pheochromocytoma, so this is obviously arising from the adrenal cortex. Pheo is arising from the adrenal medulla. We do see occasionally adrenal gland tumors in cats. These are most commonly arising from the adrenal cortex, and you will see hyperaldosteronism. So it's a very unique syndrome called Conn syndrome. We see it in people as well, but this is, it's a pretty rare diagnosis in cats. Okay, so once you have the diagnosis of an adrenal tumor, you need to interrogate that case and try to find out if it's coming from the adrenal cortex or adrenal medulla. Generally, we will do an ACTH stimulation test followed by a low-dose dexamethasone suppression test, and that will let us know whether this is coming from the adrenal cortex or as far as does the dog have hyperadrenocorticism. If it doesn't, or if it does, generally prior to surgery, we will treat these cases with trilostane for 2 to 3 weeks with this dose. And what this does is it binds up the steroid, and we don't have any literature yet, but potentially it may reduce signs related to the PUPD from the hyperadrenocorticism. Maybe it reduces thrombotic risk. We don't know. And then once the tumor comes out, we'll give these dogs a dose of dexamethasone, and then the following day we will determine what their adrenocortical axis is, and we will see if they need to have a continued dose of steroids, or if we can get them off the steroids, depending on what the adrenocortical axis is. If our endocrine investigation suggests that this is not hyperadrenocorticism, then either our rule-outs is that this is a non-functional tumor or this is a pheochromocytoma. Certainly there can be clinical signs related to a pheo. These animals can have episodic elevations in blood pressure. They can have lethargy. They might have no signs at all. But if you are worried that this is a pheo, we will generally treat these dogs with phenoxybenzamine. This dose for 2 to 3 weeks prior to surgery. This is essentially an alpha blocker. And what this will do is it will try to reduce some of the blood pressure variations that occur during the time of surgery, during tumor manipulation. Our anesthesia team generally wants this drug off the day before surgery so that some of these receptors can become available in case they do need to treat with an alpha agonist. So this was an older paper in 2008 on phenoxybenzamine in dogs undergoing adrenalectomy for pheochromocytoma. And, you know, I won't bore you with the exact details, but essentially in the dogs that were pre-treated for a median duration of 20 days, you know, those dogs had a significantly decreased mortality. So we have continued on this theme. So any dog that we're suspicious of a pheo, we will pre-treat with phenoxybenzamine. Okay, so, you know, and again, if there's any questions, please, you know, interrupt me. Let me know if there's any questions that arise as we're going through this presentation. So as far as diagnostic imaging goes, it's very important. Ultrasound is a good screening tool, but, you know, if you have the availability, I would recommend doing a CT for all these cases. You know, you can determine, is it a candidate for minimally invasive surgery? Is there, you know, invasion into the caudal vena cava, which is here? Is there, you know, closeness of proximity to the renal vein? You know, these are all things that I'm really, really interested about. You know, an adrenal tumor can be very, very different depending on the side, depending on whether it's caudal pole or cranial pole. So just to orient you on this CT scan, so here is the caudal vena cava. Here's renal vein of the right kidney. You can see the ureter coming from the right kidney. Here's renal vein, left kidney. Renal artery is the smaller vessel. Obviously, this is the left kidney. So this is the cranial mesenteric artery, celiac artery, and this is a large cranial pole adrenal gland tumor. You can kind of see there's a single vessel over top the adrenal gland. This is called the phrenico-abdominal vein. And then the caudal pole of the adrenal gland is here, and this is normal. So, you know, this is probably the ideal tumor for laparoscopic resection. It's very non-invasive. It's far away from the vena cava, far away from the renal vein, you know, an ideal case. CT's definitely been shown to be more sensitive than ultrasound for determining if there's vascular invasion. So if there's vascular invasion, you know, we still do those surgeries. You know, in fact, we had 2 last week. But, you know, that's not something that I want to be surprised about when we go in. I want to know that info, and that will also, you know, tell us we can't do this laparoscopic. It'll also help tailor the discussion to the owner. So I think, so I think some important findings. You know, if you want to try to do this laparoscopic, I probably wouldn't do any tumors that are less than or that are greater than 3 or 4 centimeters. Obviously, if there's vascular invasion, that's a contraindication for laparoscopy. Left-sided tumors earlier in the learning curve. That's what some people say. I mean, I don't necessarily think left-sided tumors are easier. You know, if you look at this CT scan, so this is, again, this is caudal vena cava. This is a little bit of the pancreas here. We've got the kidney, left kidney here, left renal vein, and then a caudal pole adrenal tumor. I mean, this is going to be a very challenging dissection across the renal vein. So you can garner a lot of information from the CT scan. So here's a video of this is a 10-year-old female spayed German Shepherd, classic diagnosis of hyperadrenocorticism. We're worried about adrenal cortical carcinoma. And let me just play the CT scan. So this is that image that I showed you earlier, actually. I mean, this is your dream case. You know, really non-invasive, left side cranial pole. You know, I would definitely recommend, if you have ability and interest in doing this laparoscopic, I would definitely suggest this would be the perfect case to start off with because it's going to be far from any major structures. Again, this is another suspected adrenocortical carcinoma, 13-year-old female spayed Bichon. Now this one is a little bit different. It's still left-sided, but as you'll see the adrenal tumor coming into play, look at its association with the renal vein. You know if you're going to get into this one, whether it's open or laparoscopic, this is going to be a very tight plane. Really advanced dissection will need to be performed there. If that plane is fibrous, it'll be very challenging. If it's not fibrous and relatively easy, it'll peel away. So that's information that you want to know, again, prior to going into surgery. So this is a right-sided tumor. So 11-year-old female spayed chow, suspected pheochromocytoma. And, here's the left-sided tumor, right-sided tumor. We know that, if there's a tumor on the right side of the adrenal gland, there's going to be close association with the caudal vena cava. You just have to assume that that's going to happen just based on the anatomical location of the adrenal gland and its proximity. You can see it here, proximity to the caudal vena cava. So the other benefit of the CT is that if you do see vascular invasion, then that's not going to be a case that you're going to do laparoscopic. So we see a bunch of cases where the tumor has started to creep up into this is the phrenico-abdominal vein, caudal vena cava. Cranial is here, caudal is back here. So we've dissected out the tumor all the way to the phrenico-abdominal vein, and where it's inserting into the caudal vena cava. And then, we've placed vascular tourniquets. In case there's hemorrhage at this point, we can occlude this segment of the vena cava to repair this. But what we've done in the following picture is done a venotomy of the phrenico-abdominal vein and pulled that tumor thrombus out, and then subsequently ligated the phrenico-abdominal vein. So, you want to know if you need to do this type of a procedure prior to getting in, prior to surgery. And that's, again, where that CT scan is really, really important. Okay, any questions up until now before we start talking about laparoscopic adrenalectomy? Okay, well, this is some key instrumentation if you are going to go down the road of doing laparoscopic adrenalectomy. You will need 3 or 4 of these 6mm cannula. I really like the threaded cannula. You will need perhaps at least 1 larger diameter port, so 12mm port, and that is to insert a specimen retrieval bag to get the adrenal out. A 30-degree telescope. I really prefer the 30-degree. It helps look around corners compared to the 0-degree. A vessel sealer is of great importance, and a J-hook monopolar electrosurgery probe. So here is the J-hook probe. This is really, really nice for dissecting, and you can get into some really tight planes with this monopolar surgery probe. You just hook this probe onto your standard electrosurgery pencil. And excellent instrument. I use the suction irrigation a lot, so I use this trumpet valve suction tip. What this does with this valve, as you depress this valve, it doesn't remove all of the pneumoperitoneum inside the abdomen all at once, so you can be careful with that. And then some type of a specimen retrieval bag. That's so that you don't contaminate the edges of your incision with the tumor as you're extracting it from the abdomen. Now, I use this single port device a lot. It's not a necessity, but I use it especially in bigger dogs. Okay, so how about operating room setup, patient positioning? This is a pretty good image for setup. the dog is going to be in semi-lateral recumbency, so you want to have the monitor across from you. This would be for a left-sided lesion. And, you don't want to attach the top drape onto the back table, just so that you can have a little bit of freedom to move around the animal. And then here is the animal, the dog positioned here. I like to still prep in the ventral midline in case we have to convert into an open celiotomy, but ensure that you rotate them into adequate lateral recumbency, because that will greatly aid in visualization of the adrenal gland. All right, so here's the animal draped in. The head to the left of the screen, tail to the right. So what we've done is, here is ventral midline. So this is draped in the field. And then, just on the other side of rectus abdominis muscle, I've inserted a Sills port. This is that single port. And then, 3 other ports in triangulating fashion around the adrenal gland. And there's certainly no rule on how many ports you can put in. If you need more ports to help with visualization, certainly go for it. There's no, it's not a competition in any way or any rules on how many ports you need to put in. And this is in a smaller animal, smaller dog, where I didn't want to use the Sills port, so I just placed a 6mm port. Again, just on the paramedian location, on the other side of rectus abdominis, lateral to rectus abdominis. Now that this is how you can make that approach for paramedian access. It's a video I got from one of my colleagues, Phil Mayhew, and an approach is made just to these abdominal muscles. And this is where, I generally don't use a Varus needle, but the Varus needle comes in very handy here. So, you're dissecting down through the external and internal abdominal obliques. And then once you get to the transversus, then you can, insert the Varus needle as seen here. Connect your CO2 insufflation hose, and then insufflate that way. It's a very safe way to gain your pneumoperitoneum. And then once you've got pneumoperitoneum, you can place one of these screw-in ports, and then subsequently watch your port go into the abdomen. And that's the beauty of these threaded ports. They really do all the work. And you can see exactly when you get into the abdomen. So a nice video there just showing how you can get paramedian access. Okay, so a little bit of familiarization with the vascular anatomy. It's important. So again, let's look at the left adrenal gland. The gland is bisected by this phrenico-abdominal vein, and this vein then splits. So phrenico-abdominal artery and vein, actually, it turns into the phrenic vein and the cranial-abdominal vein, and it's got a corresponding artery as well. I have missed this vessel in some cases, and so just be familiar that there's going to be a large vessel in the caudal aspect or the lateral aspect of the adrenal. It can cause considerable hemorrhage, so always look for that and seal it. There's branches from the adrenal artery coming from the gland. These vessels can be parasitized in cases of tumors, so there can be lots of small little vessels around this adrenal gland, so beware of that. The right side, obviously very close to the caudal vena cava, again, phrenico-abdominal vein. There's adrenal arteries that will come, and potentially other parasitized vessels that will insert or join to the adrenal gland supplying the tumor, so be aware of those. So what are some keys to success? Let's talk about left-sided adrenalectomy. It can be technically challenging. It really depends. I mean, look at the intraoperative images on the bottom. This is that dream case that I was talking about. Large cranial pole tumor. This is going to be a fairly straightforward case. And, if you can, this would be the case that I would start off with. Versus, this is going to be a very challenging case. Same, it's a left adrenal mass, but, this is caudal pole. This is going to be nestled, against the renal vein, and, will be a challenge to to dissect. So, the first thing that you need to do is start dissecting the plane here between the kidney and the tumor, and then identify the phrenico-abdominal vein and seal that. And then, be careful with the renal vein if, you have a caudal pole adrenal tumor. So let's look at some examples. This is that dream case again. So I use an instrument just to retract the kidney. And, I'm still, even though this is a cranial pole, I'm still, I want to know where that renal vein is. You can kind of see phrenico-abdominal vein coming into play there. This is that J-hook electrosurgery probe that we're just using to take down some of the peritoneum. It's really nice because you can kind of pull away with it and ensure that there's just a thin layer of tissue over top. And you can kind of see that phrenico-abdominal vein coming into play. And then I'll just take some hemostats, laparoscopic hemostats, and then dissect out that phrenico-abdominal vein. Now I just have standard hemostats. You can use right angle hemostats. And then I'll bring the vessel sealer in there to, finish off the job with the phrenico-abdominal vein. And then again, we're just continuing getting some the peritoneal attachments off from the cranial pole. And then this is that cranial abdominal branch. I'll just pause it. You can kind of see the cranial abdominal branch. There's an artery and vein there. And so, definitely be wary that that vessel is there, and don't forget to seal that. Otherwise, it will cause some brisk bleeding. So there we go. Tumor removed, and that should be placed into a specimen retrieval bag. So here is a much more challenging case. This is that case that I showed earlier, caudal pole tumor nestled against the renal vein. And I don't know, just looking at the CT, I don't know how challenging that dissection is going to be. It would not be wrong at all if you said, hey, I want to do this open. The laparoscopy, I'm just not going to get the haptic feedback on how that dissection is going to go. I think that would be totally fair. We did this laparoscopic, and we dissected it all out and then had to identify where the renal vein is. So here's the renal vein, phrenico-abdominal vein. And then, we're just being very gentle. This is a cotton-tipped swab, and, really just trying to find a plane. And I don't know, is this going to come off or not? Just being very gentle. I'm just using the tip of the vessel sealer here. And, literally just peeling off that renal vein from the tumor. It turns out it wasn't that fibrous of a plane, and we were able to, free this from the renal vein without any issues. But, be careful with these. If you have any hesitation, certainly convert to an open surgery, because, we all know this can be even a challenging surgery, using open techniques. And just being patient in there will help you. Very gentle movements. And, just be aware that the renal artery is also behind there. I mean, I'm more worried about the vein, to be honest, because it's much more thin-walled. You can kind of see the artery pumping in the background. So that's that tight plane along the renal vein and that dissection. Certainly something that you want to be familiar with, or know that that's going to be the case based on the pre-op CT scan. So what about the right side? You know, we know the right adrenal gland, the capsule is continuous with the, you know, tunica externa of the vena cava. You know, the dissection from the cava can be challenging. Definitely J-hook, monopolar cautery or electrosurgery probe is important. Suction, a fine tip vessel sealer, you know, those cotton tip swabs. And if you have any hesitation, you know, certainly convert readily. Here's an example of a right-sided tumor. There's the CT scan. This dog I saw had a prior liver lobectomy. And when we did the liver, you know, we knew the dog had an adrenal mass, but we wanted to pre-treat it prior to, you know, getting the adrenal gland out. So we just did the liver lobectomy and then came back about a month later. So here is for orientation. You know, this is the diaphragm. This is the right kidney. Cranial is to the right. Caudal is to the left. And so this is the phrenico-abdominal vein. And I generally try to seal that caudal aspect pretty early on in the dissection if I can for these right-sided tumors. You can't always. And then we're actually getting the more cranial insertion here, not an overly invasive tumor actually. There is a you know, fairly tight plane here against the cava. And so that's, you know, here's the cava wall. This is the plane that we really need to be, again, gentle with, careful maneuvers. You know, we're using the vessel sealer. We're going to get the J-hook in there as well and just get that tumor. Here we go. The J-hook is nice. You can kind of see the plane and just short bursts of energy. You know, certainly don't want to have anything prolonged. And, you know, because the vena cava is literally, you know, a few millimeters away. But, you know, this is not an invasive plane or a fibrous plane in this case, which is great. We knew on the CT scan it wasn't invasive. And then, you know, we're gently just working away, putting some lateral retraction on the adrenal gland if we can. You know, it's really cool as you can see some of these nerve attachments to the adrenal tumors, which you can never appreciate in open surgery. And then just gently dissecting away the adrenal tumor. Just be careful of the diaphragm. You're very close. Certainly diaphragmatic rupture has been reported as a potential complication. So specimen retrieval, a couple of options. I mean, most times in larger dogs, I'll insert this specimen retrieval bag to protect the edges of the wound. And that's a nice way to ensure you're not going to have any port site metastasis. The next case, this is an image, this is from a cat. So a really small tumor, we were able to fit that in the thumb of a surgical glove. So certainly saved the owner a couple $100 on the specimen retrieval bag, but it achieves essentially the same function where the tumor is not, has no potential to contaminate the edges of the wound. So one thing that we always discuss, and we mentioned this, is that, you know, adrenal cortical carcinoma in people, highly metastatic, highly invasive disease. You know, if we have tumor capsular rupture, as you know, here's an example. You know, what's the story? Is that more likely in laparoscopic? I mean, we don't know. But I guess the bottom line is it doesn't seem like, you know, this is that aggressive of a disease in dogs, which is, I think, fortunate for us. You know, there was a study by Jimenez Pelez in VetSurg 2008. They had 5 of 7 Cushingoid dogs that had capsular penetration. And you can kind of see that that's happened here. And they had no recurrence of clinical signs. So, you know, I'm obviously not advocating, you know, be aggressive with these tumors, but I think we're lucky that this is not an aggressive disease or invasive or metastatic disease. And if tumor capsular occurs, it's not the end of the world. But, you know, certainly try, minimize capsular rupture, penetration, and, you know, if this does happen, you know, I will just put a cotton tip swab against that, try to suction some of that out of the way, and then remove that suction tip and get another one so that I'm not continually contaminating the site. And then what about hemorrhage? Do you always need to convert? You know, this is potential complication. I mean, I don't think so. It really depends on your comfort level. You know, sometimes you have these little bleeders, something like this. And, you know, I think this is from some of those parasitized vessels to the adrenal gland. And I think even just a little bit of time, sometimes I'll just let the dissection go. And even put a little bit of pressure. You can even put some pressure just by pushing on top of the tumor, or just gently putting pressure in the area, or even just leaving it like this, and within a few minutes it will stop on its own. Other cases that I've had that I have converted is to open surgery is where that plane along the renal vein is you know, too fibrous, and I haven't been able to sort of resect or dissect in that area, and I've converted those to open surgery. So post-op, you know, in cases that have Cushing's disease, you know, you can certainly consider doing TEG in those cases, so thromboelastography, pre and post-op, just to sort of, you know, garner thromboembolic risk. You know, it's always interesting. It'd be a good study. We still have a lot of work to do, obviously, but does laparoscopic adrenalectomy reduce the risk of embolic disease? I don't know. You know, and then this is what we talked about. The next day, we'll do a resting cortisol. If it's low, then an ACTH stim. If it's normal, then we'll discontinue the steroids. If it's abnormal, we'll do a tapering dose of steroids for a couple of weeks. Monitor for Cushing's disease, potentially repeat, or just continue to monitor with resting cortisol levels. So what's the evidence out there? This was a study, the only study out there right now actually comparing open versus laparoscopic adrenalectomy, you know, done by Phil Mayhew's group at University of California, Davis. Some significant findings. So there was a greater number of tumor capsular rupture in laparoscopic cases. I mean, this was an interesting finding because, you know, this was retrospective, and whether you will find this info in a surgery report, I don't know. You know, I'm not sure how detailed all of your surgery reports are. Maybe you would have included that. But, you know, this is gathering some more evidence for laparoscopy, specifically for adrenalectomy. Shorter surgical time, shorter days in hospital, shorter post-operative time in hospital. So that's some really nice data to support the use of laparoscopy for adrenalectomy. I mean, I think the biggest thing is you really have to find the right cases, and you know, then you will optimize your success. So what about cats? You know, we do see these cases in cats. It's rare, but we certainly have a bunch of these cases. I like to use the 3mm instrumentation. Really handy. And then what I do is I just put one of these converter or reducer caps on a 5mm port. So this is a you know, a 5mm to 3mm reducer cap, or you can also just change the cap from a 3mm to a 5mm cap if you're inserting a 3mm instrument. Kind of a very similar setup in cats as dogs, so kind of left lateral, while I like to keep the ventral midline draped in the field. There's port placement. Now, one problem that you can have in cats is that, especially with some of these heavier ports, is that their body wall is so thin, and you know, you can have this situation where the port just, you know, travels in and out, and you can have leaks. So what I'll do is maybe place a purse string suture around that port site just to prevent any CO2 from leaking. So here's an operative, a video of the operative procedure in a cat. I can, it's a longer video, but I can fast forward to some of the key points. So this is, you know, all 5mm instrumentation right now. I will show you when there's 3mm instrumentation. These tumors can be buried in the fat, a lot of fat in cats. And, you know, we don't really have a 3mm vessel sealer on the market. There is one out there, but that would be ideal. But, you know, unfortunately, most of us will just use a 5mm vessel sealer. This is a cranial pole tumor. You kind of see the phreneco-abdominal vein here. Same principle, where we're just trying to highlighter abdominal vein is. 3 millimeter instrumentation here now, and this is where things get a little bit dodgy, in the sense that, you know, the renal vein comes right into the cava at the level of the phrenico-abdominal vein insertion, so really tight plane here. And, you know, I think it would be totally fair at this point to convert to open surgery if, you know, this plane is getting too tight. I totally understand. So here is, again, here's phrenico-abdominal vein. Here's a renal vein coming right in there. We're sort of avoiding that area right now. And then 3 millimeter instrument right now. Just taking down some of the peritoneal attachments. Seems to be opening up for us very nicely. And then we've kind of isolated just where the phrenico-abdominal vein is. Obviously, we're sparing the renal vein. 3 millimeter instrumentation is really nice again in this area. And now we've got a short stump on that phrenico-abdominal vein, and it is a little bit scary for me. I wish I had a 3 millimeter vessel sealer, but we just have a 5. And with that stump, you know, that's where we end up sealing the phrenico-abdominal vein. So much tighter planes. It's much more technically challenging in a cat than a dog, but you know, can be done. Just removing these final attachments. Oh, and then let me just fast forward to where we were. Then we end up, you know, putting in a thumb of the surgical glove, like I showed you earlier, and you know, placing the tumor in the glove. So it can be done, definitely in cats, definitely a bit more challenging. So again, pick your cases wisely. So, you know, just to finish up, you know, one of the things that we should think about moving forward is, you know, is the reduced complication rate, reduced pancreatitis in these cases, just because there's less retraction. So we need to evaluate that, looking at the oncological outcome. Is there any difference between laparoscopic and open? Ultimately, oncologic outcome is everything, and we need to make sure that we are not violating any of those oncologic principles. Postoperative pain, hospital stay, you know, those would be really good values to, and even opioid use, those would be really good values to evaluate and compare between open and laparoscopic adrenalectomy. But you know, overall, I think this can be a very rewarding procedure, and you know, something that as you do more of these cases, your expertise will only grow. So with that, you know, once again, I thank ISVS for the invitation to give this webinar. Really appreciate that, and I'm very happy to entertain any questions.
First and foremost, thank you, Dr. Ameet, for sparing some time being with us for the second webinar. It was great to have you there. In terms of questions, we have a few basic questions to you, because probably what you are diagnosing and treating is still to catch the way it is in our country. So how do we differentiate on an ultrasonography or an ultrasound the normal and the abnormal adrenal gland? It's a question from
really good. Yeah, really good question. So on ultrasound, it's been shown that any adrenal gland enlargements more than 20 millimeters, so more than 2 centimeters, those are concerning to be malignant tumor.
Okay, so it goes by size and no other dimensions to it. Any other changes do you observe on a CT scan?
Yeah,
or
definitely. Yeah, definitely. If there's invasion into the vena cava, obviously that's not a normal finding. Size is a big thing. You can see definitely asymmetry, and then the CT scan will help you with, you know, exactly, is it cranial pole, is it caudal pole, Is there invasion into the vena cava? How close it is to the renal vein?
Any differences the adrenal gland has of a cat and a dog?
Not really. It's just size. Obviously, much smaller in a cat than in a dog.
What percentage is unilateral and what percentage is bilateral in your experience? And in case we have a case of a bilateral, how do you suggest to proceed further?
Yeah, really good question. So the unilaterals are 97% of cases. Very rare to have bilateral tumors. If you do have bilateral tumors, certainly that can be treated, but you just have to warn the owners that you will have to eventually, or not eventually, after surgery, you'll have to treat for hypoadrenocorticism.
Okay. Any other complications which are common with the extraction of the tumor post-surgery?
I mean, there can be lots of different complications, especially early on when you're first starting these. Don't hesitate to convert to open surgery. There's nothing wrong with that. Every case that you at least do a portion of laparoscopic, you will learn more and eventually build up to, getting this done totally laparoscopic if that's an interest for you. The complications, I mean, bleeding, that's a big one. And, certainly that's concerning just given how close the adrenal is to the vena cava and renal vein. So that's probably the number one thing and leads people to convert, readily, which is not a bad thing.
That brings us to the end of the question answers. Ameet, we thank you for being there, for taking all of your precious time and being with all your Indian friends out here. We thank you on behalf of all. And of course, there's a frequent comment from the listeners as well as from our organizing team that the presentations were very well drafted, very well made, and made it more appealing. We really liked and enjoyed it.
Well, that means a lot. I was hoping to come to India this year, and next year I don't know whether that's going to happen, but looking forward to the time when it can happen, and hopefully seeing all of you then.
I think it will happen next year, and you'll surely come to India next year. So with those good wishes, we say thank you to you and see you another time, and virtually as well as anytime practically into India. And that brings us to the end of the session. Yeah, thank you. Thank you to all. Thank you. We are ending the session. Thank you.
Okay. Thank you. Stay safe.